Hello and welcome to another 5 Minutes With. I'm delighted to be here with my co-host, Dr. Phyllis Murphie, PhD, and today we're joined by Dr. Joshua Kovoor.
Hi, nice to be here. Nice to talk to both of you.
Nice to meet you too.
So Joshua, that horrid question in an interview. Tell me about yourself.
Yeah, well, I'm a general practitioner. I, at the heart of it, always consider myself a generalist. I like doing all sorts of things, and I have a specific specialist interest in sleep medicine. I think of that relating to my field of general medicine, thinking about the people I see in everyday life, but also with a very specific focus, in particular, on chronic insomnia and obstructive sleep apnea. And of course, the overlap between the conditions as a completely separate sort of phenotype and condition as well. But then amongst all of that, still thinking about all of those slightly less commonly presenting sleep conditions that might still turn up to primary care. So yeah, that's what I've been doing and trying to encourage some of my GP colleagues to do a little bit better in primary care as well.
I think that's great to hear, Joshua. The sleep apnea is the condition that just keeps on giving. It's just, there's so many, it's like a spider with so many legs. And, you know, it just keeps on giving us lots of new things to worry about. And, you know, how you know, it's central to the health of everybody. So yeah, it's really nice to have that primary care involvement where patients are actually at. That's where they are.
Yeah, absolutely. Yeah, and I think it's knowing that these patients are turning up in primary care and turning up elsewhere in the community. Of course, Adrian, I know some of the work that you've been doing, which is incredibly important. And I think of it as that pyramid of, most people are not necessarily ending up straight away in any sort of sleep disorders unit, but they're presenting in the community to us, to community pharmacists, to general practitioners. And so I think it's really important that we get it right.
I think that's important for sure. And the new NICE approved home sleep apnea tests as well are something that will help us to streamline waiting lists. And I think we're going to see a lot of new technology coming through in this space, which I think is really interesting as well.
Yeah, I
absolutely agree. And taking your point, Joshua, yes, community pharmacy and getting them past the heuristics of, there's your sedating antihistamine. Come on, we can do better than that. And never mind the fact it's explicitly do not recommend in the guidelines, but we can do better than that. The issue has always been, I don't get paid. So so community pharmacy has this blended revenue system, which doesn't impact a GP perhaps quite the same way, but where's the incentive to offer first line therapy, digital CBTI, if you don't get paid? So this is a challenge. It's all very well to make it free, but it's not. There's no incentive for community pharmacy to take the time, and until that's addressed, then that we have a sort of a mismatch at the coal face.
Yeah.
Anyway, moving on then. So that brings us kind of neatly into the awake check. So the awake check is what we're trying to do now. So Phyllis, I'll pass the ball so I don't keep hogging the airtime.
Thank you. So the awake check is a UK adult study that we actually have been working on now since October 2024. And the idea came from
25,
yes. And it's one of our co-researchers, Daniel Perez Chada, is from Argentina, and he used social mass media to do a study and look at using the stop bang score and finding out about some prevalence data from Buenos Aires, basically. And I read the clinical paper and I thought, that is a really great idea. And I thought, could we replicate this in the UK? So got in touch with Daniel, got in touch with Adrian, and then more people came on board. So we're now at 2,046 as of today. So we're getting close to our 50%, but we need to get to that 5,000 because of we can't talk about prevalence until we get the right number.
Can't use that prevalence word. Not yet. So yeah, we've got a fantastic team. But yeah, so it's about trying to get to the point where we can understand how common these symptoms are. That's it. I mean, to give us some current data. So just with the awake check combines the stop bang and the license from the Murphie Trust and is that right?
BSPSS.
The Insomnia Severity Index. We got the awake check direct, the stop bang directly from Janet Chong, University Hospital Network, Toronto, I think it is. Anyway, so under license. Yeah, so we've put the two together and recognizing the question about bias within, or gender bias within the stop bang. We've asked a few more sort of questions. We haven't interfered with the logic of these instruments. We've asked additional questions. So yeah, conditional additional questions. That's the right way of putting it.
And basically they're really interesting screening tools, aren't they, in terms, well, insomnia severity index perhaps not necessarily validated as a screening tool, but stop bang certainly.
Arguably.
And,
I'm gonna contest that one because it has been validated as a screening tool.
Oh, okay, interesting.
Yes, that's where we were, but the later research we've seen, it has, yes, it does have validation as a screening tool, which is an interesting one. Yes,
I mean, it's a really useful tool, isn't it? Because we use it for not just that baseline sort of consideration of insomnia, but we also think about it as as someone might have their therapy for insomnia, particularly CBTI, you know, along the way, and kind of marking how they improve. And certainly there's validation there as well. So it's a really, you know, potent, these sort of questionnaires and tools can be incredibly useful, can't they?
Yeah,
it's a beginning. It's a beginning. And if it raises awareness, and just ask the question, very simple, 5 minutes, get some information, and then what you could do about it. If it just poses the question, gets people thinking about it. It's not a big step.
Yep, certainly not making a diagnosis and claiming to be, but to assess possible risk, and for the patient to be able, or the person to be able to take that piece of paper and bring it into yourself as a GP and say,
go and talk to the GP.
Yeah, I'm a bit concerned. Yeah, exactly.
Yeah, so I think that's immensely helpful, because there's an enormous population in the you know, there's enormous population of people who do have clinical insomnia and we're talking specifically, I would be talking specifically about chronic insomnia, or insomnia disorder as it's being called, you know, rather than acute insomnia, which, you know, arguably 100% of people get at some point in their life. But insomnia that becomes problematic and persistent. And I think that's really important, isn't it? And a lot of people are not aware of it as something that can be addressed effectively. Yes. And general practitioners included, but particularly the people suffering with the condition, are not really aware that that's something they can bring to their doctor. And in theory, the doctor, you know, whoever might be doing the assessment should be able to help them with that issue. And I think there are complexities around it. I think, you know, certainly insomnia is there, and using the ISI and stop bang could be incredibly useful. But, you know, then we need those follow-up questions. Are we really dealing with insomnia? Is this sleep apnea? Is it COMISA? Is it something entirely different? Is it a circadian sleep-wake disorder? And so there are interesting questions that come next, isn't it? So there's this
absolutely. But we've got to start with the beginning. You know, we get some current data, and we don't have that current data, but yes, absolutely. Then downstream from there, but you know, we could get into my favorite systems information model, Phyllis, but we won't talk about that right now. Anyway, on that note, let's wind it up and say, Dr. Joshua Kovoor, thank you so much for joining us at 5 Minutes With.
Thank you very much. Lovely to meet you.
Thanks so much. Lovely to meet both of you.
Take care now. Bye-bye.